is a periodontal pocket. Periodontal pocket is a pathologically deepened gingival sulcus. So here you can see in the normal gingiva, healthy gingiva, the sulcus epithelial attachment is at the cement to enamel junction. As we have seen in gingival diseases and all that, the advanced stage of periodontal breakdown after stage 3 of gingivitis, if it is not controlled, it can result into formation of a periodontal pocket formation. Okay, periodontal pocket is a very important clinical feature of periodontal diseases. So here you can see, because of the presence of local irritants and causing the inflammation in the gingiva, resulted into a pocket formation. And here you can see there is a migration of the epithelial attachment onto the root surface. You can see the bone loss over here. You can see the inflammation into the connective tissue. Epithelium has been thinned out and maybe ulcerated and necrotic. So these changes occur and results into the pocket formation. Now let us see what are the pocket classification of the pocket. Pockets are classified as gingival pocket and true pocket. Now this is a gingival pocket, also called as pseudo pocket. Now when we call it as gingival pocket, when there is the enlargement, in cases of gingival enlargement, there is a coronal shift of the gingival margin on the tooth surface, resulting into pathologically deepened gingival sulcus, which you can see over here, okay, is a gingival pocket. Now in the second case, you can see the epithelial attachment has migrated onto the root surface, and that is why it has resulted into periodontal pocket, that is also called as true pocket. So gingival pocket is a pseudo pocket where there is no periodontal destruction which has taken place, okay. So epithelial attachment has not migrated onto the root surface, whereas in true pocket you will see the epithelial attachment migrated onto the tooth surface. So this is a true pocket or a periodontal pocket. Now in cases of gingival enlargement, if patient doesn't maintain the oral hygiene and all that, you might find gingival pocket as well as pseudo pocket. This is called as combined pocket. So that is also the classification of the periodontal pocket. Now periodontal pockets are again the periodontal pocket or true pockets are again classified as suprabony and infrabony. Now here you can see in the second diagram, the base of the pocket lies coronal to the crest of the bone. So this is a suprabony pocket. Now here in the second diagram you can see that the base of the pocket lies apical to the crest of the alveolar bone, and the pocket wall lies between the adjacent bone and the tooth surface. So this is a infrabony type of pocket. Now if you see the bone loss in the suprabony pocket occurs as a horizontal type of bone loss, and here in the infrabony type of pocket you will find the angular type of bone loss. You can see the crest how it is distracted, and the base of the pocket is apical to the crest of the bone. Now here in the suprabony pocket you can see the transseptal fibers which are arranged perpendicular to the tooth surface, whereas in the intravony type of pocket the transseptal fibers will be obliquely arranged. So these are the differences between suprabony and infrabony type of pocket. Now let us go to the classification according to the surfaces of the periodontal pocket. This is the simple pocket, this is compound pocket, and this is complex pocket. Now simple pocket on the right side of the diagram, now you can see one wall is involved, it is called as simple pocket, or one surface is involved of the tooth, that is a simple pocket. Now if the pocket is present on more than one surfaces, maybe two surfaces or more than two surfaces, one surface, then it is called as compound type of pocket. And third one is a complex type of pocket, which is seen in the bifurcation and trifurcation areas of the multi-rooted teeth, where the pocket originates at one place, but it takes a spiral route, and when you probe that time, you will find the origin at some other surface. So these are the complex type of pocket, okay, which are generally seen in the bifurcation areas. Now what are the clinical features? Almost all of you must have seen in last 2 years so many patients. The signs of the periodontal pocket are enlarged bluish red gingiva with rolled out edges, reddish blue vertical zone, break in facial continuity of the interdental papilla. There is a gingival bleeding which you can see over here. There can be a purulent exudate. There is looseness, migration, and extrusion of the teeth and development of diastema. Now, all these signs may be present in many cases, or there may be one or two signs which may be present in a periodontal pocket, because depending on how much is the involvement in every tooth and every patient. Okay, so it is very important, that is why that careful probing along each surface is a must. Okay, ideally you should have the 6-point probing so that you can check on every tooth whether the pocket is present or not. Now you can probe it with the Williams graduated probe on all the tooth surfaces, and you should check whether there is a presence of the pocket. Now symptoms are localized pain, patient complaints of localized pain, foul taste, urge to dig into the gums, radiating pain deep in the bone, sensitive to hot and cold, patient may complain of mobility. So these are the different symptoms with which patient will come. Now, what is the pathogenesis? Pathogenesis of the periodontal pocket is changes involved in the transition from sulcus to pocket. Okay, that bacterial plaque on the tooth surface results into inflammation. Now, the change of the bacterial flora from the gram-positive to gram-negative, from non-motile to motile, colonization of aerobic to anaerobic in the subgingival plaque, that is spirochetes and motile rods, they accumulate in the gingival sulcus and cause the periodontitis actually starts in the connective tissue of the gingiva, and in the connective tissue there are degenerative and inflammatory changes which takes place in the connective tissue. Now these changes which takes place in the connective tissue causes the destruction of the connective tissue fibers, and as well as there is an inflammatory exudate and all that. Now inflammatory cells also increase. Now when it occurs just apical to the junctional epithelium, the apical areas of the junctional epithelium start sending retipex into the connective tissue. Simultaneously, polymorphonuclear leukocyte, as you know, are the defense cells. They go into the epithelium and then through the into the gingival sulcus. Now these cells increase in the volume and they go into the epithelium, junctional epithelium, and they increase in volume. Almost it increases more than 60% volume. That time there is a the cohesiveness of the tissue reduces and the tissue starts getting detached from the tooth surface, and thereby the junctional epithelium starts migrating onto the root surface, and then it results into a pocket formation. So this is in short the pathogenesis of the periodontal pocket. Now here you can see the diagram which shows a periodontal pocket which is formed. Okay, here you can see the plaque which is present in the periodontal pocket. This is the pocket wall, this is the connective tissue, and this is the bone. Now what happens when there is a pocket formation which takes place? There is a dental plaque which is present. Now plaque causes gingival inflammation. Gingival inflammation increases the pocket formation. So because the depth of the pocket again increases, again there is a more amount of plaque formation. So this vicious cycle is there which we need to break. Now if we break this vicious cycle, then only we get the success of our periodontal therapy, and that is why it is very important, or that is the rationale behind doing a periodontal therapy, is that we need to remove the plaque and plaque retative factors. So maybe if there is a plaque present, calculus is present, so calculus is retaining the plaque over it. We have to do a thorough scaling, root planing and all that, then only the inflammation will reduce and pocket reduction may occur. So this is the rationale behind the doing periodontal surgery. Now what is the histopathology? Histopathology of the periodontal pocket is that, remember, pocket has a two wall. One is a soft tissue wall, one is a hard tissue, root surface wall. Soft tissue wall of the pocket, here you can see this is the soft tissue wall of the pocket, and this is a root surface wall of the pocket. Now soft tissue wall, as I have told you, that it causes, there is a collagen destruction which takes, collagen fibers destruction takes place. There are more number of there is more number of inflammatory exudate, there are more number of inflammatory cells, there are as well as there is pocket wall also shows the epithelium, shows the thinning of the epithelium as well as necrosis of the epithelium and ulceration of the epithelium. So these proliferative and degenerative changes which occur in the soft tissue wall of a pocket. It is also called as lateral wall of the pocket. It is also called as soft tissue. So in case you are asked in the viva, maybe what is a soft tissue or a lateral wall of the pocket, both are same. Okay, so this is a soft tissue wall of the pocket which shows the bacterial invasion. Now these bacteria have been found onto the in the gingival sulcus. They are found in the epithelium, as well as they are found in the connective tissue, as well as in aggressive periodontitis cases and all that, you will find even on the bone surface also. So bacterial invasion has been shown in epithelium as well as connective tissue and over the bone also. Now, what are the mechanism of bone destruction? Mechanism of bone destruction is by two ways. One is bacteria also cause the tissue destruction by producing toxins, exotoxin, endotoxins, or it can cause the produce enzymes or their end products of bacterial metabolism, as well as host which tries to engulf these bacteria and tries to kill those bacteria, but in a process of engulfing these bacteria and killing these bacteria, host cells also produce enzymes and all, and they also cause the tissue damage. So the mechanism of tissue destruction occurs by both the things. Now let us see that root surface wall. Root surface wall shows the changes as structural changes, chemical changes, and cytotoxic changes. So if you see here, bacterial plaque which is present over here, okay, which is continuously present on the root surface, is as the pocket forms, the Sharpie's fibers which were present normally over here, they are destroyed. They result into presence of structural granules under microscope. So structural changes you will see as areas of pathological granules. You will also see the chemical changes, areas of remineralization, areas of demineralization. So in a pocket you might see sometimes root resorption which is taking place, because this is now the root surface is exposed to oral cavity. So there is areas of remineralization, areas of demineralization. Sometimes you will see root caries, sometimes you may see root resorption, and that is why when you probe, that time the patient might sometimes say pain. That could be because of the root caries or root resorption which has taken place onto the root surface. So this is about the changes in the root. And then the third is the cytotoxic changes which has taken place, that the toxins which are endotoxins which are produced by these gram-negative organisms, they go deep into the cementum and dentinal tubule. Now, if we don't remove these cytotoxins, which are endotoxins which are present into the dentinal tubules and cementum, and if we close the flap, or after doing a scaling and root planing, okay, the pocket is going to get reinfected because of the presence of endotoxins. So we need to do a thorough scaling and root planing. Then only we are going to remove all the plaque and these endotoxins that will be removed completely by doing a thorough scaling and root planing. So that is very important. Now let us see clinical and histopathological features of periodontal pocket. Gingival pocket wall has bluish red in color. We have seen as a sign of this one. Why bluish red color comes? Because of the circulator stagnation and cyanosis, and then there is a breakage of the RBCs into hemosiderin, so which gives a bluish hue color to the gingiva. There is collagen destruction which takes place. That is why you will see the soft and then inflammatory exudate is there. Then you will see edematous type of gingiva. Okay, so these are the changes. Now you will see sometimes, even if there is a pocket present, okay, gingival wall may be pink and firm. Now why this gingival wall is? Because fibrotic changes predominate over the exudation and degeneration. Now remember one thing, periodontal lesions are healing lesions. So if it is not that always destruction goes on. When there is a destruction goes on, our body tries to repair those changes, okay, and that is why the fibrotic, when there is a exudation and degeneration going on, the fibrosis again starts on the other side, and that is why sometimes you will see the edematous pockets, sometimes you will see fibrous pocket. Does that mean the gingiva has become pink and firm, there is no pocket? No, these changes are taking in the outer surface. So inside there is a pocket. So you need to probe the gingiva carefully. So careful probing is very important, whether it is a pink and firm gingiva or it is a edematous and inflamed gingiva. Then bleeding is elicited by gently probing soft tissue. Now why bleeding is elicited? Because we know that we have seen the epithelium is thin, necrosed, and sometimes ulcerated. So and there is an increased vascularity. So this is a mechanism of our body. If there is inflammation, there is a increased vascularity. Now these vessels come very close to the epithelium, and because these vessels come so close, the moment we probe the pocket, there is a bleeding from that. So this is the reason for that. Then there is a sometimes pain is there because of the ulceration of the pocket wall, and pus may be expressed by applying this. Now remember one thing, pus occurs in pockets with suppurative inflammation of the inner wall. Now if there is a presence of pus, definitely it shows a inflammation of the pocket wall, but it is a secondary sign. Pus doesn't show the severity of periodontal disease. Pus may be present in a shallow pocket, and pus may be absent in a deep pocket. So when there is a pus is present in the pocket wall, it shows the suppurative inflammation of the inner wall of the pocket. Now let us see periodontal disease activity. Periodontal disease activity is fibrous. There are periods of quiescence and there are periods of exacerbation. As I told you that there are periodontal lesions are healing lesions. Why? Because there are disease activity. So there can be a period of destruction which is going on, or that is a period of exacerbation or period of activity. It is followed by a period of quiescence or a period of inactivity or a period of remission. So there are these periods are going on in the, so that results into fibrous and edematous pocket. So there is a change of flora from gram positive to gram negative, aerobic to anaerobic, motile, non-motile to motile, as well as the pink and firm of the firmness of the gingiva results as a fibrous pocket, or you may see spontaneous bleeding, purulent discharge, red inflamed gingiva in a edematous pocket. So these are the period of disease activity. Now, periodontal disease is also site specific. So don't think that on the buccal surface there is no pocket, lingually there will not be. It may be present on the lingual side, it may be present on the basial side. So it may be present on one side, other side may be going in the period of quiescence. So that is why the probing, careful probing is very important. Now, relationship of the attachment loss and bone loss to pocket depth. Now, what determines the severity of periodontitis? Let us see what is loss of attachment. Now, in this diagram, I'm just showing you loss of what is a periodontal pocket. How we measure with the Williams graduated probe. Okay, first we will see how do we measure periodontal pocket. From the crest of the gingival margin to the base of the pocket, we measure the pocket. So here, in case if we consider this as a 6 millimeter of pocket or 7 millimeter of pocket, okay, here the pocket is only of 2 millimeter, and here the pocket in the third diagram is 0 millimeter. So loss of attachment is from the cemento-enamel junction up to the base of the pocket. Okay, so these arrows, what you see is the base of the pocket. Okay, now from the cemento-enamel junction to the base of the pocket is a loss of attachment. That means our bone loss and attachment loss has occurred almost 5 millimeter. Now 5 millimeter, but the pocket is 7 millimeter in the first case. Second case is showing 2 millimeter. Third case is showing 0 millimeter pocket. But loss of attachment in all three cases is same. So loss of attachment shows the severity of the periodontal disease, not the pocket depth. So that is why you must always measure loss of attachment also. In the second diagram, you can see the pocket of the same depth, but loss of attachment is different. So that is why severity of the periodontal disease is assessed by loss of attachment. Now there are abscesses of the periodontium. You must know what is gingival abscess, periodontal abscess, periapical abscess, and pericoronal abscess. You have to know the diagnosis, differences, clinical differences, and radiographic differences. You can take the radiograph to differentiate between periodontal, periapical, pericoronal, and then you have to give the proper management of those. So this is about the periodontal.